I'm Elisha Paul DeKoning, an emergency physician at Dartmouth-Hitchcock and a contributor to Tintinelli's Access Emergency Medicine. The shoulder is the most frequently dislocated joint we encounter in the emergency department, and anterior and posterior dislocations are more common. Here, we will focus on the rare inferior dislocation known as Luxatio erecta. The rare but potentially serious inferior dislocation, or Luxatio erecta, can be due to axial loading of an arm raised overhead. Patients present with the arm fully abducted and the elbow commonly flexed or held behind the head. The most common inciting mechanism is levering of the neck of the humerus against the acromion with hyperabduction of the arm, resulting in tearing of the inferior capsule as the humeral head is dislocated inferiorly. The humeral head may be palpable on the lateral chest wall. An associated fracture or soft tissue injury is the norm, with a high incidence of concomitant neurovascular injuries. This dislocation is neither clinically nor radiographically subtle. PA radiographs in the inferior dislocation show the arm raised over the head with the humeral head inferior to the glenoid. Additional imaging, such as computed tomography or MRI, is not routine and should be at the discretion of orthopedic consultation. After making the diagnosis of an inferior dislocation, obtain informed consent, gather needed medications, and, if necessary, equipment for procedural sedation. The indication for procedural sedation is multifactorial and depends upon the method you choose to reduce the dislocation, patient comorbidities and preference, and the need for urgent reduction. The details of procedural sedation will not be discussed here. In the patient that doesn't require procedural sedation, consider intra-articular injection of lidocaine to reduce patient discomfort and thus aid reduction. In some cases, this may be all the analgesia necessary. Reduction of an inferior dislocation is accomplished with a traction-countertraction method and requires an assistant. With the patient in the supine position, loop a bedsheet over the affected shoulder. Countertraction is applied toward the patient's feet. Axial traction is applied in the cephalad direction. After successful reduction, place the patient in a simple shoulder sling. A post-reduction neuroexam should be documented on all patients. After reduction, obtain post-procedure radiographs to confirm reduction and to identify any previously unseen fractures. Close orthopedic follow-up is indicated in all patients with Luxatio erecta. Patients should remain in the sling until orthopedic follow-up, typically within 5 to 7 days. NSAIDs may be used for outpatient pain management. Opioid analgesics will likely be needed for breakthrough pain.